Dr. Naren comes from a very prestigious institute in Bangalore called Naren. I guess I know all of you know about this institute. It's very close to me because I've done a lot of my training over there, and I hold this institute very, very close to my heart. He's currently heading the cataract department and refractive lens services, and he's also the vice chairman of the entire Naren group of eye hospitals. He has an extensive training, which is needless to say from an institute like that, from Moran Eye Center in Singapore, SNEC. And he specializes in all sorts of cataracts, premium IOLs, complicated cataracts. And I mean, it's no point telling this forum, but he's given innumerable talks in all symposiums everywhere. So I guess it's always a pleasure listening to you, Dr. Naren, and I'm looking forward to this one.
Thank you for the kind words, Dr. Samesh. Can everyone hear me?
Yeah.
Yes, sir.
Fantastic, fantastic. Okay, on this onset, I would like to thank AIOS and Alcon for giving me this opportunity. Today, I'll be talking about 3D visualization system. Now, when you see the evolution of microscopes, it started in the early 1920s with the unicular microscope, and in the late 1920s, we had the binocular one, and the modern microscope came in the 2014. But actually, are we progressing or regressing? So this is where the Ingenuity system or the 3D system comes into picture. It started in the 2018, and it has taken care of three people. First, the consultants, then the patients, then the trainees too. So let's look at the first, the consultants. You know, as you all know, I think it's been an ophthalmic occupational hazard where a lot of us have neck pains, back pains, and so on and so forth because of constant, long OTs and on the slit lamp. Everywhere you're sitting in a very awkward position. But with the coming of the 3D system, it has made us so much more comfortable. As you can see in this video, this is my first surgery where I'm just sitting comfortably, my neck relaxed, back is relaxed, and I'm just looking at this screen and operating. Actually, in fact, sometimes I keep forgetting that actually I'm seeing a screen and operating. It is so much more, actually, it's really beautiful to operate on. Now, when we look at patients, how are we taking care of the patients by using the 3D system? We are using much lesser illumination, which is like a boon for the patients. They are so much more comfortable. You can see here I'm operating with just 5% illumination. And the patients, in fact, they tell the next day that, sir, this time I was so much more comfortable. The next thing is the trainees. Oh my God, for the trainees, this is the tool to go for. So the learning curve has really shortened for trainees by using the 3D system. And you're not limited to one trainee or two trainees to look in the microscope. You can have n number of trainees just wearing cheap 3D glasses and looking at the screen, and you're good to go. And there is no discrimination between a new trainee and a senior one. Anyone from day one of OT, he can wear the glasses and look at the screen so that from day one, they get used to the depth perception, which is a very, very important factor to learn quickly and pick up your skills. So it doesn't matter what grade of cataract, you're rest assured that you can do it very comfortably with the 3D system. Here you can see me doing a soft cataract. Yes, you can do a direct chop even in soft cataract. It's just that this is I'm doing just under irrigation. The key thing is you have to do it very slowly. You can't just do a quick chop. That's when you go, cheese wire through the whole thing. And once you have done with the chopping, I think the rest of it is pretty easy. Now, when you look at the NS2 grade, again, chopping is so much more simpler. One small tip is when you get a good hold of the nucleus, please do not move your tip because when you move your tip, you create iatrogenic zonular breaks. Always keep it still once you have a good hold. Coming to the next is the intermittent cataract. In fact, this is my first case on the Ingenuity. You can do your rexes, seamlessly, just like any other standard operating microscope. And here you can see me even washing the viscoelastic just below, which is stuck on the endothelium. That is the detail that you can really beautifully appreciate on this 3D system. Now you can see that for a second, I hold the posterior capsule and then immediately release. This can happen only if two things happen. One is if there is no lag in the system, and second is if your reflexes are good. So that shows how good the 3D system is, there is absolutely no lag. You don't need to worry about it at all. Even in these kind of really bad black cataracts, you can easily operate. A small tip on operating these kind of hard cataracts is to have a clear cornea the next day is, first thing is to keep your phaco tip in the center. It should be at the iris plane. And please do not move your tip when you're pressing step 3. A lot of people have a habit of shaking the tip when they're pressing, emulsifying the piece. Please do not do it. So that way you have much more control. You know where your tip is. You know what is happening to the PC. So you'll have a very controlled environment. Now we did a study looking at comparing the ease of visualization and comfort of a surgeon and also post-operative outcomes of Ingenuity and standard operating microscope. So this was a prospective randomized single sequence study where we included all grades of cataract, which were uncomplicated, and we excluded complicated cataracts. We did clinical examinations, and the primary objective was to see how, with what ease the surgeons are able to visualize, and also how comfortable they are, and we scored them. And also the secondary endpoint was how easy was it to do the different steps of the surgery, and also look at the post-operative outcomes like corneal edema and antechamber cells. This is how the scaling was done. And when we look at the results, there was a significant decreased illumination used in the Ingenuity as compared to standard operating microscope. And also, if you see the second chart, there is a significant lower brightness used in the 3D system as compared to SOM. And also, when you look at the comfort, the surgeons were so much more comfortable operating at the lower illumination in the 3D system as compared to a standard operating microscope. But there was no difference in terms of comfort doing the different steps. There was no significant difference, be it the SOM or the 3D system. All surgeons were pretty comfortable doing all steps. The surgeons had much better neck comfort while operating the Ingenuity, because they were, they don't need to bend forward and look into the microscope. And when we look at the post-operative corneal edema and antechamber cells, there was no significant difference between the two groups, except one surgeon had lesser corneal edema and anterior chamber cells in the Ingenuity group as compared to SOM. So I'd like to conclude by saying that all the surgeons were able to operate at a very significant lesser illumination and brightness on the Ingenuity. The patient, it provided better neck comfort for the surgeon. Also, the patients were significantly more comfortable and more cooperative, which is very important, because the more they're comfortable, immediately they become more they become more cooperative, and for the surgeon also it becomes so much more easier to do the surgery. And definitely Ingenuity of the 3D system is a hands-down superior tool in training the students. And I truly believe that the 3D system is a stepping stone for the future, where when the telesurgery comes, we are already ready, because we are already trained in operating this 3D system, where we're just looking at a screen and operating. So if you're so used to the 3D system, then the telesurgery will be just a cakewalk. Thank you for your time.
That was a great talk, Dr. Naren. And I think, apart from the 3D part, you brought out some very good salient points about trainees moving their phaco probes and causing occlusion breaks, which is such a big problem. And training them on that only is, I think, one of the biggest challenges. So when it comes to 3D, I saw that you're a superior surgeon. You sit superiorly and you operate.
Always temporal.
So do you find it difficult to move the TV screens from left to right, or is it smooth for you?
Actually, the thing is, what we need to do is we have to have a plan. You have to plan your OT. If you plan your OT well and you have movable beds, you just have to have, attach those wheels to your beds. And once you've attached your wheels, actually you and the TV or the microscope does not need to move. You can plan it in such a way that, the other bed, the patient is getting ready and so on and so forth, and then simply comes here. And if you're operating on only one bed, it becomes much more easier. You just have to, the patient lies and patient's ready, and you just have to tilt the bed, and then you're good to go. It needs a little bit.
That's very interesting. That's very interesting. I never thought of it that way, actually, because I was moving the TV from left to right, but this makes far more sense. So I think great tip over there. Also, I just wanted to know if you feel the stereo in these 3D visualization systems is better or more exaggerated than you would normally see on a microscope?
Definitely. I mean, see, I truly believe exaggeration is better,
Yeah.
because when you exaggerate, that means, let's say if something is you think that you're operating with this much size, you're operating with this much size, automatically already when you're viewing through the 3D system, you're getting adjusted to the depth. Okay.
Correct.
So when you have a lot more space, your precision will be much more better, because you know how close you can go, how much more space it has. So you immediately get tuned with your hands and eye coordination. uh, Definitely it is something like zooming into something and operating zoomed out.
Yeah.
It's a sim.
Yeah, that's exactly what I also felt, especially for trainee surgeons who find it very difficult to gauge depth, this can come. It's so unfortunate, that only the most experienced surgeons with the best resources will get this technology when it should work the other way around. The trainee should have this first, and they'll get so much to learn out of this 3D surgery.
Very true. Very true.
So do you also feel that there is a lag time? Because I sometimes felt, if the process is going on really fast, that there's a millisecond lag. But how does it bother you in a real time scenario?
Absolutely nothing. And I mean, I've timed my surgeries. In fact, I usually operate about 5 to 6 seconds per surgery, and I have not found any difference from a 3D system to this. I personally haven't. Even the fastest, because I usually operate at the high settings where I use 700 vacuum, 60 flow, and around 30 IOP. With this kind of settings, also I didn't find any kind of landing. And I showed you a video also where, for a second the PC just got caught in aspiration port. If there was a lag, definitely there will be a PCR. There is no doubt only about it. But because there was no lag, instantaneously I could act accordingly and then release the pusher capsule.
Yeah, I think that's something that we all have to understand, that with it, not all 3D systems are the same, and certain companies, they it all depends on how good your processing and your camera equipment is, because that lag time is going to make all the difference. So a homegrown 3D apparatus will not work for a surgery. It might work for you to show a 3D surgery post-operatively, but during live surgery, it's very important that any lag can cause a problem. So that's when good companies are investing so heavily on reducing that apparent lag time, which I think again a very good point. But I wish we get rid of this TV. If we can get rid of the TV and get some sort of glasses where you don't really have to have another big equipment, it would be a much bigger advantage for us.
I think very true. In fact, this is the first suggestion when they came with the 3D system. I had told them, in fact, we can have a VR headset and also have one secondary camera, because it's not just we require a view on the eye, because sometimes we need to view our surroundings, once in a while, to see where our hand is, or sometimes to see I mean whatever it is. So if you
Absolutely.
have an extra camera on the VR headset where it's have a wide field camera where you can see things around, so you can switch to any of it. Either you get into the surgical field, or you can look outside. I mean,
Absolutely.
I feel it's the way to go, but I mean, they're a little bit struggling in terms of uh, the depth perception. I have no idea, but I feel that is the way to go.
No,
So
I
they
think I
said that.
think I think this is where it boils down to. We went from microscopes to TV, and from TV we are going to move on to VR and then to AR, where you'll even see the diagnostics flipping in front of your eyes while you're operating. So I think that day is not far. Should happen.
Very
Yeah.
true.
I think. Thank you, Dr. Naren. It was a great talk and a very great interactive discussion with you on this.